Good morning and welcome to our Indiana Hospital Association Sepsis Topics and Bundle Compliance. I hope you enjoy the humor this morning with the frozen, but the other idea is that we need to just let it go, any resistance to the sepsis bundle, and get on with doing this work. We thank you so much for logging on today on this very cold day, but a couple housekeeping items. Do make access for you to do audio either through your computer or through the phone call-in number. We will have a Q&A session at the end, and we want an active participation by our hospitals. You need to mute your phone until we get back to the Q&A in case we do have some breakthroughs of your music. We don't want to hear your hospital hold music, so mute your mics. We would like to have an active chat room during this presentation, and at the top of your screen you will find a black bar that you can open up. If you click the more, you can open the chat, and my goal is to have questions and comments coming through because inevitably this is complex information. I will miss something that you think is very important in your hospital, and we're going to monitor this chat room along the way, not to slow us down too much because there's a lot of content. But and the Q&A at the end will have an opportunity for you to share your innovations at your hospital. And there we go. So our mission here at IHA is to advance healthcare in Indiana by engaging, creating health cultures, create reliable systems of care, and prevent patient harm. So through that mission, we prevent harm, we improve community health, we increase patient-family engagement, and we lead a culture of safety. My name is Rebecca Hancock. I'm in the room here with my colleagues from the Patient Safety Center, and I want you to know that every single hospital employee, of which hospitals are members that have chosen to join IHA, are members of IHA. So you are members of IHA by the affiliation with your hospital. We're talking today in our first of 4 webinars for sepsis across the continuum. The topics this next 4 months will be sepsis bundle compliance, sepsis screening, post-sepsis syndrome readmissions, and prevention. The purpose of this is to cover the pre-acute, the acute, the post-acute, and prevention phases of sepsis work. We'd like to begin, if we have Anita online here. Anita Keller. Are you on the line here?
Okay, now can you hear me?
We can hear you now, Anita. Thank you so much. I want to introduce Anita Keller, who's the Chief Nursing Officer at Johnson Memorial. She did this incredible podcast during Sepsis Awareness Month that highlighted her experience with sepsis and the work that she did. So Anita, if you would please share some of your experience along the way with sepsis, your personal experience on a Connect to Purpose story, we would appreciate it.
Well, about probably, I guess, 4 years ago now, because everybody had just started working on sepsis, and I had a urinary tract infection that I was trying to treat by myself because, you know, I can treat everything by myself. So I was doing that, and then I ended up, what we found out in hindsight was that I had a cyst on my kidney that ruptured. So they weren't sure if I got septic from the UTI or if I got septic from the cyst that ruptured. We weren't sure, but I had all the symptoms. I mean, I woke up and came into work, and I thought, you know, I was at a meeting outside of work, and I got done with it about noon, and I thought, there was something seriously wrong with me. I had a fever. I could tell that my heart was racing. Higher, you know, my heart rate was high. I just, you know, when patients say that they have this feeling of like it's like doom or like there's something seriously wrong with me and I don't know what that is. And I had those feelings, and I thought, I need to go home. So I went home, and my husband's retired, and I went in the door and said, you need to drive me to the emergency room because there's something really wrong with me now. And he's like, well, thank heavens, because the night before I'd had that ruptured cyst, and he went to take me then. So we went in, and I went into the ED, and I told the physician, I said, I'm really sure I have sepsis. And he laughed and said, why do you think that? And I said, because I know I have a UTI, and I had this thing happen last night, and then I feel like I have a temp, my heart rate's up, my blood pressure, I can feel it's up. You know, I don't know what my lactate level is, but I just know I have sepsis. And he checked it and said, yeah, you're septic. And so they admitted me, and I was in the hospital for 3 days and got better and all that. But, you know, I always tell people that you can, you know, literally you could die from a UTI if we don't take care of ourselves. And I think the other thing was I was lucky because I had been working on this project internally, and I knew what the signs were. And I knew that it was serious, and I knew I needed to do something about it. So, you know, I always say the more that we can educate the public to know the signs and symptoms, I think the more lives we'll continue to save. So I'm a big advocate for everything we're doing through IHA, and when we have the sepsis month and we give out the free things and have the posters around the hospital and all that, because for every patient like me who says, that's weird, I don't feel right, I think this is serious and I probably need to get help, could save that patient's life. So that's my story.
Thank you, Anita. And just share, do you know offhand what your current sepsis compliance is there at Johnson Memorial?
Our compliance to the CMS standards is in the 90s.
Excellent. Thank you so much. I've heard your story in similar cases over and over again. I especially appreciate healthcare clinicians sharing their stories because you have a set of expectations, and you really rolled out the red carpet for them to get it right in the ED, which added to your opportunity to get out quickly with a 3-day discharge with sepsis. That's excellent. And I will say that when I was doing my research with sepsis, every professor I had almost wanted to tell me a story about their experiences. Many of our podcasts, both from physicians as well as patients, lived experience that we did for Sepsis Awareness Month involved people's personal experiences. And the goal, like you described, is to get this work done so that this sepsis does not become too personal. But if it is personal, we know how to react to it as healthcare clinicians, and therefore impacting the community, just like you described. So, Anita, thank you so much for sharing your excellent work there at Johnson Memorial and your experiences about 5 years ago, which was actually even before the sepsis bundles were out there. So you were working on it in advance. Thank you so much.
You're welcome.
Thanks a lot. So we always begin our coalitions with a connected purpose story, and that is why we're doing this here. Not only do you get data with us, but you also get narratives, very important narratives that help emphasize the work and why we're doing the work that we do. Today we're going to describe the sepsis bundle compliance and mortality statistics for Indiana to motivate us to act. We're going to identify critical steps in bundle compliance that were identified by our experts that we had do podcasts as well as some literature content. We're going to share successes from other hospitals and identify and discuss next steps. So along the way, if you hear something, you have something you want to comment on, please do so in the chat. We'll keep an eye on it. We want you to share your innovations along the way because we haven't heard from all of you. Initially, we have one audience response questions. If you have not logged on yet to do the in-progress questionnaire, are you aware of the hospital's current percent compliance with the SEP1 bundle? I'll wait a couple 30 seconds here or so as that evolves, but we may have everyone in already. A little over half of them. We have a little over half of the participants have answered. We have 73 participants at about half, but we will keep the log open, but I'm going to go ahead and comment here that 84% of the participants are aware of what your current percent compliance with the SEP1 bundle is at your hospital, and 16% are not. So thank you very much for that. We want to be aware of that as we motivate ourselves to act. Moving on to the sepsis data right now, we're trying to move from data up to wisdom with our data, and by sharing that and commenting on that, we can help move the numbers up to actual wisdom and opportunities for action. The sepsis bundle was updated, compliance was updated in Hospital Compare on November 1st, and I pulled that data from the nation as well as from the Indiana hospitals. So what this particular chart shows is that Indiana has a current compliance rate of 53%. We're ranked 41 out of 52 states and principalities, and the range of states is from 13 to 72%. If you want to plan a trip to Hawaii, you're going to be well cared for there with sepsis, or Montana, or Florida, or Colorado. Those are the top 4. So the national average was 57%, and the top decile is 79%, and this is representative of 2018 data that Hospital Compare has collected. So just want to make you aware of where we stand in Indiana. Next, we're going to talk about how we're doing individually in the hospitals. And what we have in our hospitals is a range of sepsis bundle compliance based on Hospital Compare data in 2018 from 20% up to 95% in all of our hospitals. And that, of course, is for the hospitals who are having more than 5 cases per quarter that show up in Hospital Compare. You may be submitting data and have less than that number of cases, and it will not be represented in the data. So this is 88 hospitals across the state. Again, top decile is 79% in the nation. Our national average is 57%, and the Indiana average for 2018 is 53%. I am very confident we're doing better in 2019, but we don't have a mechanism for getting that information. So what we did is I took a look at the hospital compliance data, and those within one standard deviation, which is the middle 66%, essentially, there are 56 hospitals. There are 19 who are above 69%, and they're doing well above the middle quartile, essentially, is what I'm going to call it, but not exactly. And then there are 13 hospitals who are below 39% on their sepsis compliance based on 2018 data. I look forward to working with those 13 hospitals in several ways that we will be reaching out, that we have, that we're creating. So anyway, we know who y'all are and where you're ranked, and we look forward to working with you. This is a team effort, and no one's left alone. I did want to do a shout out here to the Indiana hospitals that are in that upper region there, the top 19 hospitals. And I'll leave this here just for a moment so you can celebrate a little bit of these hospitals who are doing exemplary work with a compliance rate ranging from 71 to 95%. So great, great work by each of these hospitals, many of whom I've been in contact with and participate in some sepsis subgroups with. Great work here. You deserve to be commended. I want to note here that these sepsis guidelines have actually been around since 2004 for the Zygris trial when they were the control arm of Zygris. And that then they were rewritten in 8, and really the original ones are in 12 because that's when Zygris was discontinued. They wrote a set of guidelines that did not include Zygris. And that drug failed to be, Lilly failed to keep it on the market because of some side effect profiles, and they couldn't reproduce their initial efficacy results on the drug once everyone was getting the control arm or the sepsis bundle treatment. It wasn't proven as efficacious as it was when people were not getting the sepsis bundle. But what I want to note is in 2009, 19% of Americans were aware of sepsis, and that's out of an article. But in 2018 and 2019, both, 65% of Americans were aware of sepsis, and you can see that in the bottom right of your screen, 65%. So when Anita mentioned that we need to continue to educate our communities, we certainly do. I also want to note here in the orange, we've noted what IHA has been doing along the line. We started reporting to our hospitals in 2008. We added the Patient Safety Council, made it a top priority in 2015, and really began monitoring our sepsis mortality and improvement efforts in 2015. From 2016 forward, we've had our annual Sepsis Awareness Month in September with toolkits that we've published. We did 6 regional sepsis transitions and care programs in November and December of 18, and we did a survey in 2017, which we will be doing another survey coming up that we're working on right now. So we're well on top of it. We've been sharing data with you along the way, and we look forward to further work. So how are we trending over time with our sepsis bundle compliance? And this is based on the quarters that are present in hospital compare, and I have to keep that downloaded because it's not accessible retrospectively. But what I want to show is there was a difference between the state and our Indiana and the nation of 6 percentage points back in 2017 when they first posted it. Up to 2018, we are narrowing that curve. It went from 5 difference in late 2018, and in this last posting, there was only 4 percentage point difference on hospital compare for our sepsis bundle compliance. I want to see those at the middle to continue to improve. We've got some goals at the end, and I want to see those who are still struggling continue to improve. We want to move ourselves up and keep us improving on our sepsis bundle compliance, at least to get past the national average and head toward the top decile. So how are we doing with that? Now, of course, we can't run direct cause and effect statistics with sepsis mortality for a number of process method reasons. But what I want to show is we track and have been tracking since 2008 through APR-DRG 720 mortality rates. And APR-DRG 720 would be those patients who came in with sepsis present on admission and it was their primary DRG. This doesn't include all the ones that had secondary DRGs. They could have had secondary additional sepsis DRGs, but anyway, they fell into a sepsis DRG. We chose this way because as ICD-10, 11, 9, 10, 11 are modified, it affects how the coding goes. With this, they still fall into this bucket of care. So in 2008, we were at 15.2% sepsis mortality rate. In 2009, we were roughly 4.75% mortality rate, which over that one decade is a 69% improvement in our sepsis mortality in the state of Indiana. So as we've continued to increase our sepsis compliance, I haven't run correlation statistics, but I would say that I think there are a lot of factors in this, but I just want to note that we are continuing to improve our sepsis mortality rates in the state of Indiana. Now I'm going to switch gears to some other data to share with you, and this is all the quality departments and CNOs and C-suite have access to a data link software that we have through Indiana Hospital Association. You contribute your data to us through the inpatient discharge study as a requirement in the state. We turn it around to you with some specific reporting, and specifically what I'm talking about today is sepsis mortality. If you do not have access to Data Link and think you should, please contact me. We'll make sure you get you linked up with our Data Services Department to get your access current, your login, and many of you received an email, but we know how many didn't actually respond to that email. So know that you have Data Link available. So you can toggle between APR-DRG 720, or you can do ICD-10 diagnoses, which is the SEP1 definition. It includes primary or secondary sepsis. But these particularly are those who came in and had a principal DRG. You can see Indiana here, and some of this data I just showed that this is the trended rate by year of improvements in sepsis mortality. The top one includes palliative patients, and the bottom one excludes palliative patients. And what we've been tracking is this bottom one with palliative excluded on the previous chart. This is available to you so you can see how we are doing as a state. This is DRG, this is sepsis ICD-10 picture with primary and secondary sepsis codes. So not just falling into the DRG, but the percentage of which have secondary diagnoses of sepsis. Why does that matter? Because we've been working really hard on the sepsis bundle that come in through the ER primarily, and these may be cases that sepsis occurs after the ER experience. It was not present on admission. So the sepsis mortality rates are a little bit higher with this whole population, about 10%, but if you take out the palliative care patients, we're down to about 5.5%, which is really quite good compared to some other statistics that I'm going to share with you in a moment. Here's a picture of another data element that's available to you within your chart, within Data Link, and this is Terre Haute Regionals. And I picked Terre Haute Regional and asked them if I could share this for a specific reason. This is a picture that you have. You go in, you pick your hospital, you pick your coalition, and you pick your peer group at the top. Terre Haute Regional has been working very hard on their sepsis bundles, and I'll share some highlights later on. But as you can see in the top left graph, they went from 10% in third quarter of 2018 mortality rates down to 2.76% fourth quarter 2018, and have been staying down there for the last 3 quarters on record right here through second quarter of 2019. They are up in the 90% compliance rate with their sepsis, and I just want to commend them for this. and their associated mortality improvements. You can also compare your rates to your coalition or to your peer group down here and see how you're doing, and the state rate on the left. Our benchmark runs at a 0% because our top 10% have 0% mortality consistently across the board for various reasons and acuity reasons. But this is an opportunity to compare yourselves. This is another picture from DataLink, and this is based on ICD-10 codes, primary and secondary. What it shows is on the top left where your patient's coming from. And in this case, Terre Haute Regional is receiving most of their patients from healthcare facilities, likely to be home there, or secondarily, they're transferring from a hospital, so they're getting a fair number of transfers in. Their top zip codes are shown here. This is an opportunity to determine in what areas you may need to be doing community awareness. On the bottom left shows what your payer source is for 1 quarter. For 1 quarter on the bottom right, it shows your deaths by age group and your number of cases. So for example, in the 75-plus case, they had 31 patients and only 1 mortality for 2nd quarter of 2019. This is an example of what you can find in DataLink through your quality departments. Just want to make sure you're aware of that and celebrate Terre Haute Regional successes. We did run some data by DRG and discharge status for readmissions, and I'm just doing this as a harbinger of things to come with our 3rd session that we're going to do. But what we do know is that the #1 DRG by which patients are admitted from is septicemia. That's the highest one in the state, which ranks #1. It also ranks #10, so DRG 871, MSDRG is #1, and #10 is DRG 872. That runs for a total of over 11,000 readmissions for 2018 is what this data is. So that's an opportunity for improvement in the state. So how many patients are coming in through our ER with sepsis that we are identifying there? We have HIN data, and within the Hospital Improvement Innovation Network, which 88 hospitals are participating in, we have 2 metrics that we're tracking. One is hospital sepsis mortality, and the other one is hospital onset sepsis mortality. So it's overall versus hospital onset sepsis mortality. And what I want to note here is that 6% of our patients develop sepsis in the hospital, whereas 94% of them come in with sepsis present on admission. This is why we've been so focused on the EDs getting up with their sepsis bundle screening and compliance. So keep this in mind as you develop, but it doesn't mean we cannot pay attention to the sepsis that's occurring in the hospital, but this explains the heavy focus on ER processes and getting ER physicians engaged. I want to transition here for a moment. I apologize for talking real fast. These slides will be available to you on our Patient Safety Center website. But now we're going to shift gears and do what we call lace curtains onto the next stage, and we're going to talk about resources in sepsis care. And again, I want to encourage you to use our chat room. If you go up to the top of your screen, you can your cursor will highlight a black bar. If you click more over on the right, that will drop down your chat. Please type in your name and your facility into the chat room just for practice. And then be sure and comment and make any comments that you would like to along the way here, and we'll try to address them. So See It, Stop It, Survive It is our IHA graphic for the sepsis awareness program that we do. I want to step back and take a look at what we had in our toolkit just as a refresher, and then I want to talk about some of the innovations that were shared through our podcasts from a couple hospitals. Our sepsis toolkit this year had 9 podcasts available, and this is available at the website at the bottom. There says survivesepsis.com. Many of you received that information, the toolkits we saw. We're up to 80, so we're taking a look. I'll get to that in a minute, the data from that. Anyway, I wanted to mention here that Dr. Lindsay Weaver's presentation on Might My Infection Become Sepsis received 630 views. I'm sure she spread that throughout IU Health as she went across doing different presentations for the system. So thank you for that. But we would like for you to take a look at these webinars again, and I'm going to highlight 2 today that are specific to what we're talking about. And one is, bottom left is Sepsis Bundle Compliance Success with Dr. Kaiser, Raymond Kaiser from Columbus. He provided us with a 25-minute podcast that highlighted all the work that they've done, and as a nephrologist, he holds a unique view of what can be done with these sepsis patients, especially discussing the fluid compliance. Second one I'm going to highlight is the second one from the right on the top, Casey Barnett from Terre Haute Regional shared her 16-minute podcast on Joint Commission certification. Terre Haute Regional was the first in the state to receive Joint Commission sepsis certification. There's been 38 views, but I guarantee you will find a lot of content within Casey's presentation that will aid your cause. We'll talk about some of the other ones at another time. I will highlight, though, pediatric sepsis is in here with treatment and assessment by Dr. Arnold and Dr. Wagers up here in the top right, as well as some lived experience podcasts, which we'll get to at another time. So second, audience response. Did you use our resources, the Indiana Hospital Association Toolkit? And right now we have 61% did use the resources, 6% did not use the resources, and 18% are not sure. Well, I've just given you the survivesepsis.com website, so you go in there and learn about our resources. There's a ton of information in that toolkit, and if you have questions about how to use it, please contact me. My email is at the first and end of this slide presentation. A few notes out of this. The podcasts can be linked together. Dr. Kaiser's podcast on compliance, along with Kieran Kennedy's discussion of her concerns about her mother. She transitions from hospital to home to extended care facility back to hospital and develops sepsis. That's an excellent one to identify gaps in your care that you may see throughout her presentation. Secondly, I'll highlight Casey Barnett's again, who sepsis compliance. And one reason we have the Connect to Purpose story is that many of the initiatives within these hospitals developed off of a patient's story that they heard about, a patient narrative that experienced in their hospital, and that urged them to improve care. So I think if we haven't had that personal experience, we need to make sure we're getting the guidelines in place before that personalization occurs. Dr. Kahn, who did a presentation on the rehabilitation research that they're doing at Eskenazi, he started his program because one of his mentors was hospitalized in the ICU with sepsis. And when he got out, his post-sepsis syndrome was significant enough that they went ahead and made changes and then no one's alone with that. There are many patients who experience post-sepsis syndrome. So you can link these podcasts together to get the patient lived experience along with the clinical content. A few more toolkit resources. We separated clinical tools from community awareness tools. And particularly there's STEM school age education from the Roy Staunton Foundation, hyperlink in here. There's heavy content from 2018 on pneumonia prevention with oral care. There are table tents, and then there's Sepsis 911 community education from Sepsis Alliance that you can use to develop your own, it's actually prepackaged content and webinar for community education. So further motivation to improve our care. It was published by Reddy et al. In 2018 that surviving patients who passed the bundles had a lower 30-day readmission rate by 5%. So that's one way we can reduce readmission rate is by getting the bundles to our patients. One other way, of course, is oral care to reduce pneumonia, and I'll touch on that in a minute. So lower readmission rates if you get the bundles. Lower mortality rates. This is data that was provided to us when they first implemented the bundles back in at the end of 2017. It's kind of hard to get to in the literature, but it was provided by qualityresource.org that provides additional CMS content for us around the metrics that they've developed. Looking at all payer rates, for those who passed the bundle, they had a 95% survival rate. Those who did not pass the bundle had an 88% survival rate. If you look at just the Medicare patients, a 79% survival rate for those who passed the bundle and a 68% for those who didn't, a difference of 9%. And we look at all payer here of 95% survival rate, that mirrors what we're seeing in the state of Indiana right now for our survival rate. So I said mortality rate of 5% and the survival rate of 95%, it adds up. So lower mortality rates when you get the sepsis bundle. And of course, many know about the every hour delay for effective treatment for septic shock is a 7.6 increase in mortality for patients, not new data. So I said that the guidelines have been reproduced every 4 years, 2008, 2012, 2016. In 2018, they did a consensus conference to look at where do we need to go, what are our research priorities for sepsis and septic shock, and they came up with 5 different research priorities. Particularly, which therapies will work for which patients at which time, more personalized research, what are the ideal endpoints for volume resuscitation, should rapid diagnostic tests be implemented in clinical practice, which there's a little bit I'm going to share on that at the end, should empiric antibiotic combination therapy be used in sepsis or septic shock, what are the predictors of long-term morbidity and mortality, and what information identifies organ dysfunction? And there's controversy right now about how you define organ dysfunction. But those are our priorities for research. One other part that I want to add here is the effectiveness of rapid response team. I actually pulled this from Get With The Guidelines, and what it shows is that one of the most important things that rapid response teams do when they respond to clinical situations, and this is Get With The Guidelines, is acute MI care. But more than 10% of rapid response team resulted in code status changes. So that's an important area for us to address along the way with sepsis compliance. And also there's a 14% mortality rate for rapid response team. Again, this is from cardiac. I just wanted to mention that rapid response teams are becoming part of the acute care for sepsis patients, both in the ED as well as in the inpatient setting. Code sepsis is something that several hospitals are using to reply to the decline of patients while they're inpatients as well as in the ED. What we also know is that there's an inequity in how we're applying the bundles. This is out of the National Quality Forum data that they ran. This is another reason that we need to be consistent with the guidelines and not use our own biases in coming forward. There was a statistically significant difference in non-Hispanics versus Hispanics getting the bundles. The non-Hispanics were higher than Hispanics. There was no difference between males and females. There was a statistically significant difference with Medicare patients getting the bundles more often than non-Medicare. Well, the sepsis bundle is actually measured on all patients, not just Medicare patients. Let's keep that in mind. Hospital compared data includes all ages 18 and above. White were higher than African American at a statistically significant difference. If you include all non-whites versus whites, there was no difference, and there's actually no difference based on age. So a little different, interesting, Medicare versus non-Medicare, but no difference based on different age brackets that they looked at. So as we look at this, are there biases that are coming into our treatment or preferences as we assess patients for the sepsis bundle? That's not definitive, it's just a comment. And if you have comments you want to put in the chat room, feel free. Next, Madeline supplied us this article just recently, and it was by Mitchell Levy, who was actually an author on the original sepsis guidelines. It's called Implementation of Sepsis Bundle. Just do it. This is not Nike, this is clinical care. It was based on a meta-analysis that was done by Pepper, and the analysis was, given, this is his editorial, but it's valuable because I consider him a clinical expert to say the least. But given that the sepsis bundle saved lives, clinicians have an obligation to act now on the best available data. There is an urgent need to implement sepsis bundles widely for the benefit of the severely ill septic patients. Again, many reasons to just do it. Now I'm going to switch gears and identify some topics that have been brought to light in my conversations across the systems as we've talked to different specialists, different experts in their field. And also, this particular article is from a guideline from Colorado Hospital Association, and I've got the hyperlink at the bottom of here, and they have a sepsis education content that is helpful in some ways about identifying time zero in one of the two ways, documented by physician, APN, or physician assistant, or of severe sepsis, or when the clinical criteria are met. Some hospitals I want to mention are going with the top area here that says the time of triage in the emergency department, and that is their time zero. If they came in through the ED, they're identifying time zero, defining it as the time of triage, so that your 3-hour window starts right then, as opposed to below when the criteria all comes together. So that's a higher standard if you're using, but valid standard in that we don't want to see our throughput to affect our ability to treat our patients in a timely manner. Also on this particular piece, part of this information was coming out for this Just Do It, the 2019, based on the 2018 consensus conference that I showed you earlier. Well, I won't go all the way back there because it'll make you dizzy. But the point is that Dr. Levy decided to make this Just Do It as a response to the research priorities, so we don't get so tied up in further research. I'm all for research. Anybody who knows me, I'm all about data. Can't deny that. But at the same time, we are where we are with the sepsis bundles, and we need to continue to treat our patients as such. A few other items identified as best practice from the Colorado Hospital Association, which I appreciated because they are, I think it was #2 in the nation with their compliance. Sepsis screening is an ongoing evaluation, but at least once per shift and with a change in patient condition. I mentioned earlier that most of the sepsis comes in present on admission, but we cannot neglect those patients who are in our beds once per shift and with a change in patient condition. And I know many of you are out there doing that already. Create your standardized treatment bundle as an order set if possible. When you have the order set, it allows the sepsis abstraction to occur more consistently because you can set your abstraction items based on the order set items, such as time 0 or the volume of fluid to be infused. Thirdly, use technology as available to supplement your routine severe sepsis screening practices. Many of you have an EMR that allows background screening with looking for SIRS from your patients, and Colorado Hospital Association just notes this. I particularly like the list. Develop your process for code sepsis or sepsis alert internally and in your ED. I know some of you are doing that. Even I know right now that some of those who are even challenged by their sepsis bundle compliance have code sepsis and sepsis alert. And I will venture to say that many issues are going on with documentation and abstraction processes. And I'll mention the clinical documentation improvement opportunities in a moment. So evaluate patient outcomes and performance and give feedback to providers. Oftentimes, one comment I heard from a physician, not directly from a physician, but from an ED situation was, they made it out of my ED fine. Okay, so they made it out of your ED, but that doesn't mean they died later on from organ dysfunction. So we need to treat them rapidly with the fluids and with the antibiotics and meet the 3-hour bundle so the condition. It also, there's an article somewhere that says it shortens your length of stay. Well, value-based care is going to be all about saving money through having shorter care, shorter lengths of stay. So I've addressed mortality improvements, length of stay improvements, and also reduced readmissions here. Within Casey Barnett's wonderful podcast that she did, but this particular piece is the internal metrics that Terre Haute Regional is tracking as a part of their sepsis bundle program. So we talk about the overall sepsis bundle compliance within the state. What happened along the way in this journey is that CMS decided to back off on all their process metrics because they had so many metrics we were overwhelmed. So when sepsis came along, they backed off on all the process metrics by which we use to meet the whole bundle. However, it's still important to have internal process metrics to meet that outcome bundle of sepsis compliance overall. So Terre Haute Regional, thank you, Casey. And I know she's on the phone, and I'm going to give her opportunity to speak at the end. Antibiotic administration within 60 minutes of arrival. So they bumped it up from 3 hours to 60 minutes. Their goal is 70% based on compliance on all patients who have a code sepsis activation. So you can see there, that's how they're tracking. If there was a code sepsis activation, did they get it in within 60 minutes? And that's the goal of 70% is way beyond the 3 hours, like I said. Hemodynamic monitoring in patients with persistent hypotension following fluid resuscitation. They are putting on external monitors for stroke volume, and their goal is 100% compliance within 6 hours following vasopressor initiation. And then you also have a passive leg raise that an option within the bundle compliance processes. Appropriate fluid bolus for all patients when required. Their goal is 90% for all patients who require the fluid bolus. And initial screening accuracy with a goal of 100% of all patients screened for sepsis will have an accurate initial screening to facilitate early identification and treatment. Anyone who's doing sepsis screening with their staff has seen deficits in the actual identification and use of the SIRS criteria plus suspected new or worsening infection. We need to treat more carefully educate clearly on what the sepsis screening process are. Check on that and not only do a feedback loop for screening, but also for the bundle application. Just want to highlight Sepsis Terre Haute Regionals and how they are getting to the 90% compliance that they're currently at. Thank you, Casey, for this in your podcast previously. Dr. Kaiser shared with us in his podcast that sepsis screening is an evolution of screening, and that we need to treat it just like AMI and stroke. We know that. Cast a wide net in the emergency department with serious criteria. The difference between AMI, stroke, and sepsis care, AMI and stroke was facilitated by a number of dollars from Genentech, who produced Activates, or TPA. We don't have that privilege right now of having a drug specifically to treat sepsis. It is up to us as our clinicians to provide that care. But if you make the analogy of get with the guidelines for stroke and AMI, I think we'll move this forward. It hinges on a suspected known or possible suspected new or worsening infection. Serum lactate, rule out other causes of elevation instead of infection. That's an ongoing process that he as a nephrologist alerts people to. There are multiple causes of lactate elevation. It's a rule-out process. What I want to come back to is what are the common sources of infection. And this is a pretty good slide that I dug really deep in the literature to get. This is not published yet. My apologies there. But what it shows is that respiratory across the board is the #1 source of sepsis, except for older adults where UTIs are at 44% and sepsis is secondary at 33%. So all the time, if we can at least make improvements in prevention of respiratory and genitourinary infections, we're going to make incredible progress. But also, those are the ones that we're looking for the most. We tend to miss some of the smaller issues with soft tissue in children, and abdominal issues are huge, 8.4% in peds, 21% in all adults, and 16% in older adults. When Anita was talking earlier, one of the biggest symptoms that I saw described by patients was in some interviews that I did was excruciating pain, whereas the caregivers described it as bad pain when they were watching them, but patients described it as excruciating abdominal pain, so keep that in mind. We do know that 22% of sources are unknown based on Kumar's article, and that is where we have more difficulty with getting the right antibiotics started. Fluid boluses, there were 3 trials, Arise, Promise, and Process. There's difficulty to show the fluid bolus because both groups, both groups were getting the 25 to 30 kilogram per kilogram boluses within 3 hours. So that's a very important difference that we need to continue to do, but there was just a little difficulty with the methods in this because of where we are, that many patients are getting the control arm, the sepsis bundles. We can document the ideal body weight on a patient and give the fluid boluses based on ideal body weight instead of their actual weight. Make sure you're doing that. Some are having the ideal body weight calculated within the order set, so it's present while you're writing the orders and does the calculations already for the total volume to be infused. Dr. Kaiser notes in this that pulmonary edema is really rare. We can take care of the edema. We cannot take care of a gone organ, a dysfunctional kidney that will no longer work again. So easier to treat the pulmonary edema than that. And that's one of the episodes that I want to mention, that even though they got out of the ER alive, they may still have permanent organ dysfunction because they didn't get the full fluid bolus. Another thing that Dr. Kaiser mentioned is we need to get back to a euvolemic state before discharge to prevent our CHF readmissions. Very good note, because we still have an issue with CHF readmissions. It was in the top 4. But it's a little different statement there because CHF would have been the readmitting diagnosis, and I was talking about the admitting diagnosis in the data. Antimicrobial stewardship and involvement of the pharmacist on your team is very important to narrow to the more specific antibiotic as quickly as possible and close the loop on the specificity based on your culture review. And Dr. Kaiser mentioned the admitting provider has responsibility for that diagnosis as well as the pharmacist and the physician together following up on their antimicrobial stewardship and application of the effective antibiotic. Our 7.6% increase in mortality is related to the most effective antibiotic, and that is based on the culture report. Every hour delay in the effective antibiotic, 7.6 increase in mortality. I want to include involvement in a clinical documentation team and the interaction between your clinical team and your coding team for specifics within writing and defining different parts of the sepsis bundle compliance in your abstraction team. This is something that requires as much interaction as did AMI and heart failure clinical documentation, as that first came out in CMS's need for improvements. But sepsis is not far aside from that. Again, some may be retrospective in getting the final diagnosis as it evolves in the hospitalization, but learning the improvement process to document sepsis correctly includes clinical documentation. And I think that in many of our hospitals are having poor compliance right now, despite all their efforts. This is what needs to happen. You need to work with your abstracting and coding processes to make sure that you're on the same page. Oklahoma has prepared a sepsis gap analysis that they've shared recently in our HIN listserv. And particularly, this is a chart review tool that you are to do 10 to 20 charts, 10 to 20 minutes per chart on 10 charts, and it addresses the sepsis bundle elements and also sepsis assessments. What this does is allow you to identify gaps based on 10 specific indicators, and from there you can develop your process improvement tools. This is for all sepsis patients. The HIN also has one posted on their website that is for post-op sepsis. We have used them as a part of a pilot post-op sepsis relay that we did and modified our internal post-op sepsis discovery tool, but I can sure share either of these with you if you reach out and ask me and discuss how to implement these chart review tools. Again, 10 chart reviews, no more than 10 to 20 minutes per chart. I want to note some new evolving information right now. There's new technology. I was reading the final rule. It's like 750 pages. I really wasn't reading, and I used sepsis Control F to find what I was looking for. But the final rule, which dictates our upcoming outcome metrics and CMS's oversight of care. That's a big generalization, but it's a final rule, so it comes out every year. They note in this final rule with a lot of back and forth discussion between T2 diagnostics. And T2 has a 5-organism panel. They're noted in the third bullet point here. And they noted that 36 to 47% of patients get started on the wrong initial antibiotic. And so what they do is a yes, no, are any of these present within 38 and a half hours, as opposed to a culture taking 63 hours. And based on their intensive dialogue that's on page, can't tell you what page, well, pages 278 to 288, 10 pages. But CMS, effective in fiscal year 2020, which starts in October of 2020, has given them a code to use, an ICD-10 code that's valued at $97.50 to use if you're using this technology. Now, I believe, I can't say definitively that there's several, I'm not promoting this at all, but I believe but T2 is who was doing the dialogue with CMS and promoting this, but I believe there are several vendors who are doing this type of work, and it's based on DNA analysis to identify yes, no, they're present. There are a number of pending CDC ICD-11 recommendations pending approval in the discussion phase. They're grouping them by organism type now instead of by specific organism. They plan to delete severe sepsis because one of the updates sepsis guidelines by Society of Critical Care Medicine, who owns the guidelines, has eliminated severe sepsis as one of the diagnoses. This is pending. They are asking for feedback right now. If you have comments, the goal is the discussion is to delete SEERS and also severe sepsis. I put the hyperlink on here for you to go look at that content that's in discussion. It will affect some of our, I hope it doesn't affect how they get grouped into DRGs, but again, this is these conversions within ICD-1011 is why we have maintained our oversight of APR DRG 720 as our primary mortality measure. So what's the call to action today? View Dr. Kaiser and Casey's podcasts for bundle strategies. Plan your community education event because as I noted, 94% of your patients are coming from your community and need to be educated, and need to mention that as well. Develop your own plan to improve sepsis bundle compliance. Our goal is for Indiana to be greater than national average of 59%, or at least if you're already at the national average, we want you to be in the top decile. So that's your goal. A few resources that I put in here. There's simulation exercises the Colorado Hospital Association has posted on their website. We've also done a number of great simulation exercises in the state of Indiana through our SHIP grant to the small hospitals that was done by the Rural Health Innovation Collaborative out of Terre Haute. Close enough. And also there's a sepsis gap analysis that is from the Sepsis Coordinator Network that's hyperlinked here, and AACN has a gap analysis. I'm seeking the current one. This is one from 2014. I will get that cleaned up as soon as I get my hands on it. I just don't have AACN access. There's someone out there who has the current AACN gap analysis and wants to send it to me. I will happily put that hyperlink here. Okay, real quick before Sue Hallenbeck has a question. Sue Hallenbeck, question, when does ICD, I don't know when ICD, she says, when does ICD 11 start? I do not know that question. And I'm not sure that's been particularly published. I want to finish here and have a little bit of time for dialogue, but what I want to share, if I can find it here, is Casey Barnett's Connected Purpose story that she shared with us, attempted to share, but of course we ran out of time at our regional coalition for the Central Southwest Patient Safety Coalition. And the theme here is teamwork. Teamwork, teamwork. This is a team sport. Casey, we had a sepsis patient who presented with increased shortness of breath and was found to have pneumonia. The patient initially had an elevated lactate level and soft blood pressures, but otherwise hemodynamically stable. The patient was admitted to our med surg unit, and on arrival, the nurse noted now that the patient had a blood pressure of 85/46 after admission. The night shift nurse called the nurse practitioner hospitalist to notify the low blood pressure and the need for fluid resuscitation. The patient was quickly transferred to ICU for fluid resuscitation. The patient continued to have low pressures despite fluid boluses, so the ICU nurse notified the nurse practitioner timely and Levocet was initiated. Our respiratory therapist was able to insert an ART line timely for accurate hemodynamic monitoring. The patient was able to discharge 4 days later and reported that he felt so much better. This was truly a team effort from 2 nursing units, the hospital's NP, and respiratory therapy, all on night shift, I might add as well. Go night shift. That's where I worked. As Casey noted, I don't know how much credit I deserve for this one, but our nurses are just plain awesome. Now, we can have these success stories across the state, and I encourage you to continue work and contact some of our mentors out there. Casey has offered to do a discussion over the phone. If you would like to, I can share her information with you as well as go through me, and I will funnel out your content. Right now, I want to open up the lines. Have we had anything in our chat room about any comments or anything? Y'all are mighty silent for, I know I'm talking quickly, but I want to get a lot of information out. So, further questions or comments? We're going to open up the lines here, and make sure your phone is muted if you're not going to speak. Otherwise, background content if you're whispering things back and forth or listening to music.
700, 136, 136.
Lines are unmuted if you want to ask any questions or add any comments.
This is Anita Keller. So I assume that we're going to get these PowerPoints, correct, Rebecca?
130 or 130.
Yes, Anita, the PowerPoint will be posted on our IHA website under the Patient Safety Center. If you have trouble finding it, contact me or Casey.
Okay, thank you.
You're welcome, Anita. Thank you. Other comments, questions, any innovations that you'd like to share from your hospital that you think has made a remarkable impact that we have not touched on? And I know there are many. You can type it in or you can speak on the line right now. Casey, if you're on the line, or Chris Newkirk from Columbus, if you're on the line and have any commentary, I'd welcome that. I know that you guys have championed processes at your hospital.
Hey, it's Casey. One thing that's really helped at regional with completing bundle compliance timely is we implemented sepsis buddies in the ER. So each shift, a nurse is assigned as a sepsis buddy and a stroke buddy. So if any stroke or sepsis patient comes in, that nurse tries to go and help the primary nurse to get the bundle completed timely, whether it be for stroke or for sepsis. And so we found that that's really helped our time. So it's pretty easy to implement. It's not our charge nurse. It's just a nurse that gets assigned during the shift. So everybody kind of helps out, and it really promotes teamwork. So it's something to think about if you're having challenges with bundle compliance.
Thank you, Casey. Do you also have a paper document that follows the patient through their hospital stay from time zero to make sure everyone's aware of what's been done?
Yes, yeah. So that is told for every sepsis patient. Like you said, it follows them throughout their stay so that we all know what their time zero was and where they're at.
Excellent. And I know that I've seen many hospitals who are, oh, we don't want to use a paper document. We want to keep it on electronic medical record. But anecdotally, the hospitals who are using paper documentation just to keep yourself going during the initial 3 to 6 hours, and knowing and for communication purposes and for transitions in care purposes. Transitions are so dangerous, going from one spot to another, that's proved effective while we're during the learning process for sepsis bundles. And oftentimes hospital staff need to have it reinforced several times before it's really memorized. Other comments? Anyone out there? Thank you very much, Casey, for that.
We got something from the chat. Chris Newkirk is on, but she is on her computer and not on the phone. And she says that she knows that community awareness has been huge for Columbus Regional. She knows that the patients really feel like they know what sepsis is and what to look for, and also what to ask their provider. So that community education piece is really working in their area. And Sue Hallenbeck would like to know if you can share that form that follows the patient. They would like to be able to see that.
Sure. There are several examples actually within the toolkit. Within the sepsis toolkit, there is a, Sue, email me particularly. It is within the toolkit, but I'll direct you straight to that in the clinical resources section. And again, what we heard about community awareness that Anita echoed, she knew to come in. Of course, she was clinical, but she came in and said, I think I've got sepsis. Chris Newkirk just described that the community awareness that they've done is making a difference with patients in reducing time to treatment is the goal there. So not only do they walk in and say, could it be sepsis, but you're reducing the time to treatment, which of course improves outcomes. We've got maybe another minute. Is there any changes in our polling? We're 85% are aware of their current bundle compliance. 62% were aware of the use of sepsis resource materials. 30% were not sure, so that means that they probably don't know about the sepsis toolkit, which we're pretty proud of. I understand some people not knowing about it, but use it within your system. Anything else? Any comments from anyone else? So thank you so much. Hope this has been helpful. Let us know if you have further needs regarding education as we develop the content for the next 3 times that we meet, and we will get the Outlook invitations out to you in our many ways as we can. Any other comments? Yes? All right, we will close this with a little more let it go. And let it go, let's get on with this sepsis bundle compliance.